Good morning, everyone. Welcome to the IWH Speaker Series. Happy New Year. This is our first speaker series of 2024 that is open to the public. We have quite a large number of people who've joined today, so thank you very much for being here. Before I introduce our speaker, Dr. Peter Smith, let me just run through a couple of little housekeeping things with you. If you would like to use closed captioning, you can find it at the bottom or sometimes along the top of your screen under CC, and you can activate that for yourself and turn it on and off as you like. We often get a lot of questions. As I mentioned, we've got a lot of people here with us today. And so the best way for us to have you ask your question is to type it in the question and answer box, the Q&A box, and you can find that also along the bottom of your screen. You may have to go into the three dots to find it there. We also encourage you, because we may not get a chance to address everybody's questions, we encourage you to contact the speaker and find out from Peter the answer to your questions. The slides and the presentation will be made available to you for access after today. That usually takes a few days, up to about a week, to get that posted. Again, please ask any of your questions in the Q&A box, and I will help moderate the session when Peter's finished. So let me tell you a little bit about our speaker today before he starts his talk. Dr. Peter Smith is a senior scientist, and he's the president of the Institute for Work and Health here in Toronto. He has extensive experience conducting research related to work injury and its consequences using large population-based surveys and administrative workers' compensation data. His key research interests include gender and sex differences in the relationship between work and the risk of chronic disease and work injury, the nature and measurement of occupational health and safety vulnerability, return to work experiences for people with mental health conditions, and the long-term outcomes of injured workers. Now, today, as you can see from his title, he's going to be talking about refining estimates of occupational exposures and risk of workplace COVID-19 transmission. Over to you, Peter.
Thank you very much, Monique, and thank you to everyone who's attending today or looking at this presentation later through the recording. Just a couple of acknowledgements before I start. One is to acknowledge this particular project did not receive any project-specific research funding, although we did have a lot of in-kind support through members of the WSIB who facilitated access to the claim data I'll be using today, and employees of Statistics Canada in the Research Data Centre, which facilitated access to the Labour Force Survey, which I'll also be using today as an information source. And just to note that this work wouldn't have been possible without the core funding that the Institute receives through the Ontario Ministry of Labour, Immigration, Training and Skills Development, although I am speaking on behalf of the Institute and no endorsement to the Ministry is intended or should be inferred. To acknowledge my study team as well, Ching Lau, Faraz Shahidi, Avi Biswas, Linda Robson, Vicky Landsman and Cam Mustard, who participated with me on this project. I'll note that the work I'm presenting today is currently in peer review. We have received comments from 2 reviewers and some editors, which we have addressed, and all those inclusions, all the stuff I'll be presenting today does incorporate the feedback we've currently received through peer review, and we're hoping that we'll have a decision on this particular paper within the next couple of weeks, and at that point, it'll also be up on the IWH website along with the speaker series presentation. So I'm going to start with the key messages for those who can't stay for all of today's presentation. First key message is a data message. It's that if we really want to know how many infections are due to workplace exposures in the next pandemic, we need to make more effort right now in enabling that collection of information to happen. The information I'm presenting today, I think, is the best estimates we can currently generate around occupational exposures and work-related COVID-19 infections. But you'll see as we go through the presentation that some of the information sources are a little bit limited. And I do think we need to start thinking now about if or how we would want to measure this better during the next pandemic. And often the things we might do in that space are actually useful just for better understanding the relationship between working conditions and health outcomes, given that work is an important social determinant of health. The next three are all specific to the information I'll be presenting today. One, we looked at occupational exposures, and they were consistently associated with the risk of COVID-19 infections, even after adjustment for a variety of demographic and industry variables. While the direction of this risk was consistent, so there was always an elevated risk across waves of the pandemic, the magnitude of risk was not. And this does pose some interesting questions about why would the relationship between an occupational exposure and an outcome change throughout different courses or different phases of a pandemic. And they do highlight that potentially dynamic nature of occupational exposures and COVID-19 infection risk across different waves of the pandemic, which can help us better understand, if we understand the dynamic nature of COVID-19 transmission, again, this information could be used if it was done in real time to generate and base our prevention strategies on. So just a little bit of background before I dive into the work that I'll be presenting today. Very early in the COVID pandemic, the workplace was identified as an important setting of infection. And this makes sense because workplaces traditionally were settings where people from different communities would come together, they would interact with each other, and they would go back to their communities. And so it was obvious that given work was going to continue within certain settings, that the workplace might be an important setting of infection transmission when it comes to things like COVID-19 infection. We did have a good idea that occupational exposures that were likely to increase the risk of COVID-19 transmission included working in close proximity to other people who were infected, whether they were symptomatic or asymptomatic, indoor settings where there was poor ventilation, and working where infection control practices were inadequate. So where people either weren't using PPE or there wasn't good separation between people who were infected and people who were not infected. And so those different situations within the workplace were likely to increase risk of COVID-19 infections. But most studies that have examined occupational exposures and risk of COVID-19 have been limited in two important ways. One is a lot of studies have had to treat all COVID infections as work-related infections, or assume that if it occurred among someone who was working, that it must have been work-related. And then this doubles with the second assumption, which was often, and especially in Ontario, we had to use information from the 2016 census to identify people's working and living conditions. And a lot of things changed between 2016 and 2020. In particular, we couldn't assume, or we shouldn't, sorry, I shouldn't say we couldn't because people did, we shouldn't assume that people who were working in 2016 and going to the workplace would still be working in 2020 and still go into the workplace throughout the pandemic. So in terms of the challenges to estimate a work-related risk of COVID-19, first of all, we would ideally want to determine which COVID-19 infections were work-related and which were not. Second, we would want to be able to measure and identify occupational exposures that might be associated with increased risk so that we could estimate what is the relationship between it being in that exposure and having a work-related COVID-19 infection. That provides some challenges because measuring occupational exposures is complicated. You could try to do a survey where you asked everyone who was going to work what their different exposures were. What we opted to do was use a job exposure matrix approach, which is where we use very detailed information on someone's occupation and surveys that have been conducted previously to estimate the people within that occupational exposure group or within that occupation have this type of exposure. And then the third one, which I've talked about on the previous slide, is that we really would want to identify people who are still going to the workplace. We can't assume that people who are working remotely, working at home, would be at the same risk of a work-related COVID-19 infection. In fact, their risk of work-related COVID-19, we've assumed, is negligible and they're not included in our exposure risk group. So we opted to use workers' compensation claims to identify risk of COVID-19 infections. So in Canada, one of the fortunate things in Canada was that workers' compensation authorities decided to adjudicate the work-relatedness of COVID-19 infections. Now, this wasn't the case in all other jurisdictions. And shortly in the chat box, there'll be a link to an IWH study, which did look at the different ways the different jurisdictions around the world addressed assessing COVID-19 infections. Within the workers' compensation system in Ontario, for a COVID-19 claim to be accepted, it did require evidence that the risk of contracting COVID-19 was greater at work than the risk of contracting it within the community or within the household setting, and that there were work factors that significantly contributed to COVID-19 infection risk. And so you can see here that there is a chance that there is people who might have had a true work-related COVID-19 infection, which either didn't submit it to a workers' compensation agency, or they submitted it and it was not accepted as a work-related COVID-19 claim. But it is true that almost every claim, or I would say without a doubt, every accepted compensation claim for COVID-19 was definitely contracted through a workplace exposures. So while we might miss some claims that are work-related, or some infections that are work-related but are not in the compensation claim database, every claim that's in the compensation claim database is definitely a work-related COVID-19 infection. And when we have isolated to work-related COVID-19 infections, it enables us to examine occupational exposures and those infections with a little bit more precision. So just to put this in a diagram in terms of wanting to understand who is at risk of a work-related COVID-19 infection or a compensation claim for COVID-19. So first of all, we'd want to try and identify three groups in the labour market. Workers who are at the workplace and have a particular occupational exposure. In this diagram, I've said it's in close proximity to other workers. People who are at the workplace but didn't have that exposure. So people who are at the workplace but not working in close proximity to other workers. And then we would want to also identify people who are not going to the workplace, because if you're not going to the workplace, you're not at risk of a work-related COVID-19 transmission. And then, given we're using workers' compensation claims to identify COVID-19 infections that are work-related, we also want to restrict this group of people who are at the workplace to those who work for an employer that is required to submit workers' compensation claims. So not every workplace in Ontario is required to submit or is eligible to submit workers' compensation claims, but it's quite a large amount. About 75% of the labour market in Ontario is covered for workers' compensation through the Workplace Safety and Insurance Board. So we could, or we did think about using some of the administrative data that's available in the WSIB to estimate the size of the insured labour market. And there are two challenges with this in terms of understanding occupational exposures and risk of workplace injury and illness. One is they may not be accurate. So they're tied to payroll estimates, which may not be accurately reflect the number of people within a workplace. They're not reported for some firms, so some firms are not required, Schedule 2 firms are not required to report their payroll estimates. And then probably the more important limitation in terms of this particular study is we can't break those FTE counts down by age groups, by sex, by different occupational exposures. And we don't really know when an employer reports their payroll estimate, how many people will go into the workplace and how many people will not go into the workplace. So many of these limitations can be addressed using Statistics Canada's labour force survey, which is why we've chosen to use that as our source of information of the population who were at risk of a work-related COVID-19 infection. So the labour force survey, Statistics Canada labour force survey, it's a monthly survey conducted by Statistics Canada. Its objective is to estimate changes across occupation and industries within Canada. And so it's a fairly large sample. The sampling frame is a very comprehensive sampling frame. It's representative of about 98% of non-institutionalised Canadians aged 15 and over. It contains detailed information upon a respondent's occupation. So at a 4-digit level, there's 500 4-digit occupational codes and their industry at a 4-digit North American Industrial Classification System scheme, again at a 4-digit level, as well as person's sex, their age group, among other things. It also contains other information, which you could use in other studies, but we didn't use in this study because they weren't captured in the compensation claim. I'll talk a little bit about that towards the end of the presentation. But one of the real advantages of the labour force survey is starting in April 2020, there was a supplement to the labour force survey that asked people who participated in the labour force survey some COVID-19 relevant content. We have included some of that in some previous studies. One of the key things was, in the last week, where did you spend the majority of your time? And so we were able to isolate and remove from our at-risk population, those people who spent the majority of their time in their house, because they wouldn't have been at risk of a work-related COVID-19 infection. So, using the labour force survey and using compensation claims, we are able to isolate this sort of black box in this picture. So we can look at people's exposures, so whether they're working based on their occupational code in close proximity to others or whether they're not. We can remove those people who are not going to the workplace, and using the industry code, we can restrict the people in the labour force survey to those that are working for an employer who is required to report any injuries or illness to, they require healthcare or time off work, to the Workplace Safety and Insurance Board. So using a combination of these different data sources, we now have this box isolated through the labour force survey. And when we put compensation claims along with that, we can describe people who work in close proximity to others and those who don't, and we can look at those who had COVID-19 claims and those that didn't. So we can estimate based on the compensation claims who had them, and then if we take the total of people who work in close proximity, we can estimate how many didn't have a compensation claim. And then based on that information, we can develop a risk ratio or another type of summary measure where we can compare what was the risk of having a COVID-19 claim among those who were working in close proximity, and what was the risk compared to what the risk was for those who didn't work in close proximity to others. And that's what we've done a little bit more sophisticated towards as we started to integrate other demographic and industry-related variables. But in a nutshell, that's basically what we've tried to do by combining labour force survey data with workers' compensation claims. So the time period that I'll be looking at today covers 5 different waves of the COVID pandemic. So this here is presenting all the case counts. The case counts are the orangey boxes there, and the case rate, which is the black line. The case count and the case rate don't shift too much from each other. This is the general population. And so the general population in Ontario has tended to stay the same pretty much throughout the pandemic. And so you see that the case rate and the case count closely mirror each other. We have looked at 5 different time periods throughout the pandemic in this particular study. One was looking at April to August 2020, which we've referred to as wave 1. One was looking at September 2020 to February 2021, where you saw an increase in claims. This wave wasn't given a name. It was sort of like a wild type of COVID strain, which is called wave 2. Wave 3, which is March to June 2021, is referred to as the alpha wave. Wave 4, which is July to November 2021, is referred to as the delta wave. And then starting in December 2021, we had the Omicron wave, which is where we saw a massive increase in terms of virus transmission. I should note that during wave 5, based on the laboratory confirmed COVID-19 weekly case counts, that is probably an undercount because there was a restriction as we saw this massive increase in cases for PCR tests to only be available for certain types of workers or to certain types of people within Ontario. So that very, very steep incline you see at the very end of the very start of wave 5 is probably an underestimate of what the true increase in cases were. And then to go back to our study information method, so if we think about this as a numerator denominator issue in terms of estimating the fraction of people within a particular occupational group that had a COVID-19, work-related COVID-19 infection, at the top we have monthly estimates of accepted workers' compensation claims. And we can use those to estimate the number of infections or the number of events. At the bottom, we have the monthly estimates from Ontario's labour force survey, which allow us to estimate the number of hours that were at the workplace and the number of people who were at the workplace. We can use those to estimate hours of exposure because it's important that not everyone worked at the workplace for the same amount of time. We do 2 different adjustments to these estimates. One is we restrict them to industries which have complete workers' compensation coverage, and we do that based on the North American Industrial Classification System, which is available both in the compensation claim and in the labour force survey. And then we do a stratification. So we've got different case counts within occupational exposures, age groups, sex groups, wave of survey, and industry. What we did in this study is we looked at the healthcare industry, yes or no, versus in versus without. And then using that information, we can generate rates of work-related COVID-19 infections within these subgroups. And then we can put those rates into regression models, negative binomial regression models, where we can look at the count of rates within particular strata, and then do adjusted rates, so rates of a particular occupational exposure, adjusted for age, for sex, for wave of survey, and for the type of industry that someone's working in. So this graph presents in the blue is the number of claims that we had, which is against the left-hand side axis of this slide. And then in red is the full-time equivalent estimates of the number of people who are going to the workplace throughout the different phases of the pandemic. And to read those numbers, you've got to go to the right-hand side of the axis. So you can see there was variation. There was variation in claim counts. But more importantly, there was also variation in the number of people going to the workplace. It was quite low during the first phase of the pandemic where we had that complete lockdown. You did see it increase as we went into the wild wave, decrease slightly into the alpha wave, increase again into the delta wave, and then decrease again, although not substantially too much in terms of the Omicron wave. The important point here is that if we used a general count, say of the 2016 census of the number of people who were going to the workplace, we would have underestimated the count in different phases and overestimated it on, potentially not over, we would have underestimated, but to different degrees about different phases of the pandemic. The scale here, in terms of the misestimation, it's almost 500,000 full-time equivalents in terms of the difference in terms of the people going to the workplace and were eligible to submit a compensation claim over different phases of the pandemic. So it's not an insignificant or non-trivial amount that wouldn't bias estimates at all. So again, another reason why it was important, or it's really important, to understand the dynamic nature of the population at risk if you really want to understand what are the rates of work-related COVID-19 transmission. So now I'm going to move to rates. So the blue numbers here are the rates of COVID-19 infections per 1,000 full-time equivalents. And you can read these off the left-hand side axis. And you can see that in terms of the first phase of the pandemic, it was about 10 work-related COVID-19 claims per 1,000 full-time equivalents, increasing into the second wave, decreasing slightly, becoming very low throughout the Delta wave, and then increasing again through the Omicron wave. Cases per day here is now in the red boxes, and you can read these looking at the right-hand axis. So this is the number of cases per day among the working age populations. They're still restricting it to a working age population, noting that not everyone in this population will be employed or go into the workplace. You can see that while the trend is kind of similar-ish in that it goes up, then it goes down, then it spikes up again, the magnitude of the change wave to wave is actually very different, with the compensation claims showing a much weaker or blunted trend compared to if we were to think about cases per day among the working age population. What I'm going to do now in the next slide is I'm going to put these side by side so we can look at the relative rate compared to the first wave and from wave to wave within each of these two different data sources. So work-related compensation claims, workers' compensation claims, rates of workers' compensation claims on the left-hand side of this figure, cases per day among the working age population on the right-hand side of this figure. I'm just going to move this box here so I can see what's happening at the end here. So what we can see here, again, we see this blunted rate, and what I've presented here in blue is the rate in that wave relative to the first wave. So that's what the blue lines in both figures represent. And the red line is the rate relative to the previous time period. So for our second wave, they're both the same because they've both been referenced back to the first wave, but then you can see some shift, whereas in the third wave, the red indicates what was the rate relative to wave 2, whereas the blue indicates what was the rate in wave 3 relative to wave 1. So a couple of things to point out in this particular slide. One is that during the Delta wave, the rate of workers' compensation claims was about 1/5. So in terms of relative rates, when it's 1, it's equal. When it's below 1, it's less than. And when it's above 1, it's greater than. And so a relative rate of 0.19 is about 20%. So it's about 1/5 of the rate in the first wave among compensation claims. Compared to when we look at cases per day in the population, it's almost a twofold risk. In terms of the rate in the Delta wave was almost twice as high as it was within the first wave of the pandemic. So very different in terms of what was happening to the rates in the workplace and outside of the workplace. When we look at the Omicron wave, again, just over 2.5 times the rate in workers' compensation claims. So it increased relative to the first wave, where it was just over 10, it increased to 26 COVID-19 accepted COVID-19 claims per 1,000 full-time equivalents. We can see in the cases per day, it was an 18-fold increase compared to the first wave of the pandemic. So again, very different in terms of the magnitude of the risk in the Omicron wave when we looked at cases per day among the working age population compared to work-related COVID-19 infections using compensation claim data. But interestingly here, you can see that when we look at the change between Delta and Omicron, it's actually quite similar if we look at the workers' compensation claims compared to wave 5 compared to wave 4, and we look at cases per day in wave 5 compared to wave 4, we can see that the increase in cases per day was just under 10, and the increase in workers' compensation claims was almost 14. So a similar increased risk, in fact, a slightly stronger increased risk in workers' compensation claims. Now, this may be due to the fact that for a workers' compensation claims, you didn't necessarily need a PCR test. You could have submitted a positive rapid antigen test. You could also have taken a doctor's note into workers' compensation claims. And maybe that's why we see this slightly increased risk among workers' compensation claims between wave 4 and wave 5 compared to the cases per day. So we do see this difference in trends. And I think this has important implications for understanding work-related COVID-19 infections. One is that the magnitudes, the difference in terms of the amount of cases that were probably work-related did shift throughout the pandemic. And a problem there is that if we were to assume that it was a set amount using all cases per day, would be wrong, and that would bias our estimates. Now, you could look at workers' compensation claims and say, well, you know, we've talked about some of the caveats and not everything is submitted as a workers' compensation claims. It's possible that rates of denied claims might have changed throughout the pandemic. We did look at that in terms of if we were to compare the number of claims that were accepted to the number of claims that were denied and compare the acceptance rates among those claims. We did look at how that shifted throughout the pandemic. And in fact, it was actually largest in the first wave. So the number of claims that were denied was actually largest within wave 1. And it didn't really shift a lot in terms of the proportion of claims that were denied compared to those that were accepted throughout waves 2 through waves 5. So it's a relatively consistent in terms of rates of denied claims versus rates of accepted claims, or numbers of denied claims, I should say, versus numbers of accepted claims. I can also, and so we do have some issues here. So it's probably potentially one of the reasons why this curve is a little bit flatter among work-related compensation claims might be due to the adequacy of infection control procedures. We have done some work at the Institute where we looked at Statistics Canada's labour force survey. This was through July to September 2020. The labour force survey asked questions on, for each respondent in the survey, they asked if particular types of infection control procedures were in place. And we did find in that study, which was just about to pop into the chat box, in terms of that study, that we found that rates were actually relatively high. The one exception was people within the construction industry, where rates were a little bit lower compared to the rest of the population. Now, admittedly, we didn't capture every type of infection control procedure you would want to capture. That was because a function of what the questions that Statistics Canada was asking. But the workplace is a setting, unlike outside of the workplace, where you actually have a little bit more agency to put in place particular types of policies and procedures, and have employees who are coming to your workplace and members of the public who are coming to your workplace have to adhere with those policies and procedures. And potentially, that is one reason for why we see a flatter curve when we look at work-related COVID-19 infections compared to all COVID-19 infections among the working age population. I'll also add that it's not just in workers' compensation claims that we've noted this trend. We did a study with colleagues from Public Health Ontario earlier on in the pandemic, where we looked from April 2020 to March 31st, 2021. Here, we're looking at workplace outbreaks, which are in the blue, which are against the left axis, compared to cases which are not due to workplace outbreaks, which are in the red, which are on the right axis. And again, in this study, we saw that the proportion of COVID-19, positive COVID-19 tests went from 25% due to workplace outbreaks down to 11% during the second and third time periods here. So again, some evidence that rates of workplace outbreaks in terms of the proportion of all cases were shifting throughout the pandemic. And as I said before, that has important implications for using all cases per day to try to estimate what occupational exposures are associated with risk of COVID-19, because the number of COVID-19 infections that are likely work-related is shifting as well, as could be the risks inside and outside of the workplace throughout the pandemic. But I'm not here to say that workers' compensation claims are perfect. We know they're not. And I'll talk about some of the limitations towards the end of the study. In terms of the study which we did with colleagues from Public Health Ontario, that also should be coming into the chat box in just a second. It's been published in Occupational and Environmental Medicine. So this comes back to this first key message. workers' compensation claims are not without their flaws, but I think they're a better source of work-related COVID-19 infections than if we look at general cases per day among the working age population. But given they're not perfect, if we really wanted to know and have the best estimate of how many infections were due to workplace exposures, we currently don't have a system that's perfect. And so if we wanted to do that through the next pandemic, we really do need to have more effort made into collecting the right information that would enable that to happen. And I will talk about some of the small things that we could do right now that would not only enable this to happen, but actually really better our understanding of the relationship between work and occupational injury and illness. So, given that, in my opinion, workers' compensation claims are the best way to isolate COVID-19 infections that are work-related, given we can now isolate COVID-19 infections that are work-related, and we know that the definition of that is not shifted too much across the pandemic because we haven't seen massive shifts in terms of rates of denied claims versus accepted claims. We can now look at occupational exposures and how they're associated with risk of COVID-19, work-related COVID-19 infection. We looked at 4 different types of occupational exposures. Proximity to others at work, if an occupation was public facing or not, if it was indoor versus outdoor in terms of the work environment and different gradients in between, and the overall risk, which is based on these 3 different occupational exposures. So high, which is where people have 2 or more of these exposures, low, which is where they have 1 or less of the exposures, and medium, which is all the groups in between. We assigned the occupational exposures, as I've mentioned before, based on the 4-digit occupational code. There's 500 different 4-digit occupational codes, which are available in both compensation claims and labour force survey. And we used a job exposure matrix, which was developed by the US Council of State and Territorial Epidemiologists, their Occupational Health Subcommittee. So in this slide, I'm presenting the rates, or the rate ratio, I should say, of adjusted risk of occupational exposure and work-related COVID-19 infections. I'm presenting it just based on the 3 different occupational exposures I've mentioned. It was similar in terms of the overall occupational exposure metric about low, medium, and high. So if we were to look at working in close proximity, we can see that those in close proximity to others were almost at 3 times the risk of a work-related COVID-19 infection compared to those who were not working very closely to other people in the workplace. Public-facing occupations, 30% increased risk compared to non-public facing occupations. And those that were working often indoors or primarily indoors had an increased risk of about 1.7 to 1.9 compared to those that were working primarily outdoors. Given that we know both the rate ratio in terms of these risks, and we know the proportion of the labour market that's within each of these different exposure groups, we can also estimate what we'd call population attributable fractions. And population attributable fractions allow us to get an estimate of what would have been the reduction in numbers of COVID-19, work-related COVID-19 claims if we could have eliminated that particular occupational exposure. Now, for some of these, it's a little bit silly, so we can't eliminate working primarily indoors. But what the population attributable fraction does is it integrates both the number of people exposed and the relationship between that exposure and your outcome. And if we look at the population attributable fractions, you can see that in terms of working very close, it's about 41% of COVID-19, work-related COVID-19 infections. But for working primarily indoors, it's about 70%. And that's because so many people were working primarily indoors throughout the pandemic compared to the group that was working outdoors. And again, I think this also highlights, given we've seen different relationships between indoor and outdoor work, had we gone into workplaces earlier and made the effort to understand who's working indoors, who's working outdoors, who's contracting COVID, it would have told us a lot quicker than when we ended up finding out that COVID-19 infection was likely through the air rather than through contact with surfaces. Again, the workplace, given the setting, given the variety and different types of occupational exposures, would have been the ideal setting to do that type of study early in the pandemic, which would have informed our prevention strategies. Unfortunately, we didn't do that, and we ended up taking a lot of time to truly identify that COVID-19 transmission was occurring through the air and less of it was occurring through contact with surfaces. And because we had the different 5 ways, we also looked at whether the relationship between different exposures changed throughout the course of the pandemic. So here we're looking at not close versus very close, which is on the left-hand side of this figure, and those who are working primarily outdoors compared to those, primarily indoors compared to the reference of those who are working primarily outdoors on the right-hand side of this figure. And you can see for both of these exposures that the relationship shifted throughout the pandemic. So the relative rate of exposure for those who were in very close proximity to others versus not close was fourfold, just over fourfold throughout wave 1 of the pandemic, reducing to just under twofold throughout wave 3 of the pandemic, and then increasing to again be over fourfold throughout wave 5 of the pandemic. And again, you can see for primarily indoors versus primarily outdoors, how that shifted quite considerably throughout the pandemic in terms of the relative rates of exposures for those working primarily indoors compared to those working primarily outdoors. One of the limitations to presenting information in this way is that it's a relative rate. So we're comparing the exposed versus the unexposed group within a particular wave. And so shifts in the relative rate can occur because either the reference population, the unexposed group, their rate's going up or their rate's going down, or the exposed group's rate is going up or going down. So an alternative to that is to present relative to a consistent population. So for example, we could compare to the unexposed group in wave 1. And I'm going to do that on the next slide. And we're going to look at those who are working in very close proximity compared to those who are not working in close proximity to other people. And so again, now we're always comparing to the unexposed group in wave 1, which is on the far left-hand side of this particular slide, which is called the reference group. So you can see we have this fourfold risk during wave 1, and we can see that the risk increases for both the unexposed and exposed groups during wave 2. We still have an elevated risk, although it's coming down in wave 3. In wave 4, both the unexposed group and the exposed group are at decreased risk of work-related COVID-19 infection compared to the reference group in wave 1. That's the Delta wave, where we had the lowest in terms of compensation claims. It's about a fifth of the rate that we observed in that first wave. And then again, increasing up with the rate among the exposed group being its highest at 8.85 compared to the rate within the unexposed group in wave 1. The reason we don't see that increase in the relative risk in the previous slide is because the rate among the unexposed group, those who were not close also, was twofold compared to the rate in wave 1, which is on the far left-hand side of this figure. And so this also gives you a different snapshot in terms of the pandemic. So on the previous slide, you would have seen that the rate in wave 3, the relative rate was 1.9, and that's a function of that the rate among the exposed group and the unexposed group both came down, but the unexposed group to a lesser extent. We had the rate in wave 4, which was 2.51, but here we can actually see that both groups, unexposed and exposed, were at decreased risk compared to wave 1 in terms of the pandemic. It was just the unexposed group came down to a much larger extent than the exposed group. And so now we get, if we were to compare 5.3 to 1.9, we get a 2.51 increase if we were to compare those rates over time. So strengths and limitations, just briefly before I get to my concluding comments, noting that we're almost out of time. So we were able, some of the strengths in the study, we were able to restrict the population to the actual population who was at risk. So we were able to remove those people who were not going to the workplace throughout the pandemic, which is a non-trivial proportion of the labour market. All COVID infections that we included, because we used compensation claims, were definitely work-related COVID-19 infections. I'm not saying we captured every single work-related COVID-19 infections, but the ones that we included, the definition was relatively consistent throughout the pandemic, and the rates of acceptance and denial were also relatively consistent from wave 2 onwards in terms of the pandemic. And we were able to look at different phases of the pandemic because we had detailed information on compensation claims and labour force survey estimates. Weaknesses, general weaknesses of all workers' compensation claim studies, where not everyone submits eligible injuries to workers' compensation claims, and so you can't really use them as a proxy for all work-related injuries and illnesses. So a substantial proportion, probably over half of eligible injuries are not submitted to workers' compensation agencies. We used a job exposure matrix to assign our exposures, and noting that within a workplace, a particular occupation might have had different types of exposures depending on the infection control practices that were in place or depending on other factors that were at play. And so the job exposure matrix assumes that the exposure is consistent across everyone within that particular occupational title, which may not be the case. But on average, potentially it is. And then our inability to further adjust our models for variables like race and immigration status, which are both captured in the labour force survey data, but unfortunately not captured within workers' compensation claim settings. And there has been a speaker series about this time last year, where there was a discussion of better integrating issues around race and ethnicity into understanding return to work outcomes. So in terms of the key message from the second half of data half, so occupational exposures were associated with increased risk of COVID-19 infections after adjustment for demographic and industry variables in ways that we would expect them to. So people working in close proximity, people who are public-facing occupations, and people primarily working indoors were all at increased risk of work-related COVID-19 infections, as well as a summary measure, which I haven't presented today, but is in the paper, which hopefully will be accepted in the next couple of weeks. While the direction of risk was relatively consistent across phases of the pandemic or waves of the pandemic, the magnitude of risk was not. And I think this does highlight the potentially dynamic nature of occupational exposures and COVID-19 risk and the need to continually update estimates of who's at risk and who's getting infected throughout different phases of the pandemic. In terms of future work, so we really do need to develop systems that capture information on occupation and industry when people interact with their healthcare system. So when they visit their GP, when they go to the emergency department, we really do need to develop systems where we can integrate, hey, what sort of things do you do? What are the type of tasks you do? What type of industry do you work in? Are you currently going to the workplace? And this isn't just about preparing for the next pandemic or understanding the rates between a work exposure and an infectious disease such as COVID-19. I'll note that the recent occupational disease landscape review done by Lynn Holness and Janet Brown also highlighted this, as if we did this, we'd actually better understand the relationship between occupational exposures and occupational disease. And that's also going to link to that report, which is really an important read for anyone who's interested in the prevention of occupational injury and illness, is also going to be posted into the chat box. Current work with occupational exposures, as we've done here, basing them on a job exposure matrix and COVID-19 infections based on workers' compensation claims, we can extend that to other types of exposures. And we're doing that at the moment at the Institute for Work and Health. So we could look at different types of occupational exposures. We can look at different types of claims. So we could reduce it to critical incidents. We could also reduce it to things like fatalities, musculoskeletal conditions, other types of nature of injuries, and understand how are different exposures associated with these different types of workers' compensation claims, and does that shift over time? We could also use the labour force survey information and compensation claims to better understand how shifts in the labour market in terms of industry composition, occupational distribution, even things around if we started to capture information on immigrant status or race, how shifts in those characteristics in the labour force, how that impacts our understanding of what's happening around compensation rates and compensation statistics over time. So this is just a summary, which they've also been put in the chat box in terms of work-related IWH publications, and my contact information for those who don't get a chance or where there's not a chance for me to answer the question today. Thank you very much, Monique. I look forward to the questions.
Thank you very much, Peter. A lot of really, really interesting information. We have a number of questions for you. If we don't, so if you do have a question, just a reminder, please put it in the question and answer box. That way we can go through them. I'll try to combine some questions that are similar. And as you mentioned, if we don't get to your question, please do contact Peter and ask him directly. But here we go, Peter. In some of the research that you talked about at the very beginning of your presentation that was related to the risk of contracting COVID-19 and comparing workplaces and elsewhere. Has that other research controlled for the nature of the workplace, or is your study one of the first that's really tried to look more at the exposure itself?
One of the first within Ontario to look at, and within Canada, I'd say, to look at the nature of exposures. Other jurisdictions around the world, so the UK, the Netherlands, Denmark, they just had better systems in place to start with, and so they were better able to understand who was going to the workplace, what was their occupation, what was their industry. They were able to link that information with disease registries. It was either already linked, it wasn't hard for them to link it. So it's one of the first within Canada, potentially within North America. I always feel a little bit sheepish about saying it's one of the first because it's probably not. There's probably someone online today who's done that study and I just haven't seen it yet. But I think it's one of the first certainly within Ontario and within Canada to look at occupational exposures and risk of work-related COVID-19 infections. As I said, other jurisdictions were better set up to understand these questions over time and have actually found similar results. So that trend of decreasing risk with occupational exposures over time has been reported in studies in both the UK and in the Netherlands. We were able to extend it through to the Omicron wave, which they weren't, which also showed that it increased. So as counts within the general population increased, we also saw an increase in risk of occupational exposures and work-related COVID-19 infections.
Okay, thank you. By focusing on claims data, you were opting for specificity versus sensitivity for work-related COVID cases. Someone is asking whether you think there were groups that might be missed more often because of this approach and what those groups might be.
Yeah, so I think we could, certainly people who are not covered, who work for a workplace that is not covered by the Workplace Safety and Insurance Board, would not be submitting their claims. I mean, we've adjusted for it in the denominator as well, but that's a chunk of people who are likely, could be at risk of COVID-19 infection, which are just not included either in the numerator or the denominator. So that's a missed group. And again, had we been able to capture work information in some other source of information, a more general population source, we could have combined that with the labour force survey information because it does cover not just workplaces that are required to submit injuries to the Workplace Safety Insurance Board, but it covers workers who are workplaces that are not required to submit workers' compensation claims. We do also know from previous studies which have looked at when, done surveys when they've asked people, did you have an injury? It would be eligible for compensation claims. Did you submit a compensation claim? And we, in those studies, it's more than half of people with an eligible injury don't submit a workers' compensation claim for that injury. And there's a variety of different reasons. It's not a minority is because there's active claim suppression within the workplace. A lot of it's just because they don't think it's very serious. They didn't know about workers' compensation, or they weren't sure they had an alternative benefit system. And so, I think it's to understand whether we could generalize that to COVID-19, I think is an important question. It would have been great to see a study funded that actually did a survey of the working population. So, for example, in the UK, there's proactive surveys done on a monthly basis where they made people do a RAT test, saw if they had COVID, asked them their work information, asked them their industry information. You could have easily tacked onto it, so you've got COVID, or you've had COVID. Did you submit a workers' compensation claim for that? And we'd have a much better understanding of who submitted claims and who didn't. There were some studies which I think were quite interesting, which came out of the Peel Health region, which looked at particular groups of workers. But they didn't necessarily ask, did you submit a compensation claim? It was more around, if you're symptomatic, would you have gone to the workplace? So again, related, but not the question that we're asking. So yes, I think we did opt for, specificity in saying, if we want to measure occupational exposures in the relationship, it makes sense that our outcome is infections that are definitely work-related. But, workers' compensation claims have caveats. I think the caveats in using all cases are much greater, in my opinion, because of the shifting dynamic between work-related infections and non-work-related infections, and the shifting dynamic between exposures inside and outside the workplace throughout the pandemic.
Okay, so I'm going to combine a couple of questions here. Now that workplace restrictions are no longer mandatory, do you plan to continue to research the relationship between workplace conditions and COVID-19 workplace infections, particularly given that there's such a big increase in COVID cases overall? In other words, rather than wait for the next pandemic, are you prioritizing addressing some ongoing COVID endemic issues? And is it possible given the data that is coming out?
Yes, it's just a matter of data availability. So certainly, as far as I'm aware, there's a continuation within the labour force survey to capture information on whether people are going to the workplace or not. So the denominator, I believe, is going to be consistently measured now, and hopefully, if there's anyone from StatsCan online, hopefully into the future, because it really is important to understand who's going to the workplace and who's not, and how does that differ across occupation and industry groups. And again, the numerated data, the infections data, is still reported to the Workplace Safety and Insurance Board. I think one of the tricky things here is cases or infections that are not reported. So, for example, with our comfort with moving to hybrid work environments, if someone had a COVID-19 infection and couldn't go to the workplace, but could still do their work at home and didn't require healthcare, they wouldn't actually be required to submit a workers' compensation claim. So that dynamic does shift over time. Given what we've done and how we've set up this particular study, it can be extended easily to further do that. It's just a matter of how confident we are in the numerator and denominator data into the future.
Okay, thank you. A couple of quick questions about methods and definitions of some of the variables. The JEM, the Job Exposure Matrix by CSTE, was that developed specifically for COVID, or was it respiratory infections in general?
So it was the Job Exposure Matrix was developed specifically for COVID, but the information underlying the development of the Job Exposure Matrix was collected prior to the pandemic. So what they've got a system in the US, which is actually not a bad system, and again, something worthwhile thinking about, whether we could generalize this system or whether we should develop our own system in Canada. There's a system called ONET in the US where they do surveys of workers from time to time, and they ask them a series of questions about occupational exposures. And then they've got occupational codes. And so you could use what the CSTE did is they used selected exposures against occupational titles and looked at particular groups of occupations which had each of these different exposures. All we had to do was transfer it from the US system, the standard occupational system, to the national occupational system, which is used in Canada, which was, luckily, there's been some really useful work done in Quebec on the crosswalk, and then there's a theoretical crosswalk by StatsCan, which enabled us to do that. So, but it does remind me that the occupational exposures that we used were collected prior to the pandemic. So while they developed it specifically for COVID, we don't know necessarily if those occupational exposures persisted throughout the COVID-19 pandemic, or if there were things like shift schedules or separation of workers, which meant that those particular occupational exposures were no longer as valid as they were prior to the pandemic when they were collected by ONET.
Okay, thank you. A question, would a robust contact tracing system, which asked about workplace exposures and controls and maybe use genomic sequencing if available, would something like that be the gold standard for determining work-relatedness? And is there any contact tracing information that you know of that was gathered during the pandemic that would be of sufficient quality to kind of determine this work-relatedness?
So I'm not aware in Ontario of I mean, there was contact tracing, which was done when public health units spotted that people were contracting COVID from a particular workplace. They used to go in and see if there was a workplace outbreak. In the study that we did, Sarah Buchan's study, they actually had to code the industry information. So it wasn't collected. They had to manually go through each of those workplaces and code the industry information. So there wasn't really a system in Ontario, but I mean, from the extent to which positive PCR tests are your measure of infection, I think that could be used, but a positive PCR test usually results in some symptoms for someone to be present, which enables them to go and get a COVID test, which enables the PCR test to be done, then you get the results. I mean, so if we're thinking about little steps, yeah, sure. Within that, when someone has a positive PCR test and they do the tracing, did you go to the workplace last week? Can you tell me a little bit about the type of work you do? Can you tell me a little bit about who your employer is? Then developing systems to code that information. That's the sort of system which they have in the Netherlands, where they were able to combine that straight away with labour force survey information, which told them that this particular person is in this occupation and is still working at the workplace, and now they've got a positive PCR test, and we know that the other people don't. It doesn't cover the asymptomatic infections, and we don't know still the proportion of COVID infections. I mean, at the moment, we don't know how it's changed throughout the pandemic, but there's a substantial proportion of COVID-19 infections which are asymptomatic, and that's where similar studies like what they did in the UK, where they developed a system whereby they had a sample of people they tested monthly, and they asked them, are you going to the work? What's your industry? What's your occupation? And gave them a rat test to know asymptomatic COVID infections. I mean, that gives you the complete picture. I really think it depends on what you want to prevent. Do you want to prevent, or do you want to understand all infections? Do you want to understand infections that are symptomatic? Or in our case, do you want to understand infections where there's either a need for healthcare or a need for time off work, which is the definition of why you'd submit a workers' compensation claim?
Okay, thank you. We're running close to the end of time, but I'm going to see if we can get in a couple of additional questions. Lots of thank yous, by the way, for the great presentation. People are interested in some of the exposures, close proximity, indoor, outdoor work. Can you just quickly define what you meant by close proximity, and then maybe talk about super spreading events that we know are drivers of transmission? Does that explain some of this? But, we know that there's, distance spread occurs in large numbers of people who share the same air, but they may not actually be close to each other in proximity. So first of all, how did you define close proximity?
Yeah, so it's based on these questions from ONED, which is questions about how physically close are you to other people you perform when you perform your job, how important is you to work with others in a group or a team as part of this job, and how often do you have face-to-face discussions with individuals as part of this job. And so using those different systems, the CSTE group developed, this is who we're going to say is in close proximity and the other 4 categories. And so that's the system from ONED. The workplace outbreak stuff is, I think, really interesting. And again, another area where we could have done so much better. If you look at outbreaks, and so we've looked at the outbreak data among workplace outbreaks, and the magnitude of those outbreaks are quite different. There were some outbreaks which were massive, like hundreds and hundreds of workers. And there were some outbreaks which were quite small. Unfortunately, we don't have information on the size of workplaces, which is obviously a determinant. But imagine if we were to identify an outbreak where it spread through everyone, and a similar workplace where there was an outbreak, but it didn't seem to spread, and we had new information about what was going on in those workplaces, we would have understood so much more about virus transmission much earlier in the pandemic than we did. But the reality was we didn't get into workplaces, and though we identified it as a setting, public health wasn't prepared to get in and pick up the work information that needed to be collected. But we can address it, and it won't just be good for the next pandemic, it'll actually be good for just understanding work as a determinant of health.
Okay, terrific. So maybe one quick finish question, and I apologize, I couldn't get to everyone's questions. Please do contact Peter. But do you recommend, Peter, based on your research of what you've seen, that workplaces recommend implementing any measures to mitigate the risk of COVID-19 infections, to keep doing certain things? What would you recommend?
Well, I think there was a session that I was in for World Congress when we ran World Congress a couple of years ago at the Institute for Work and Health with CCOHS. And one of the things Tish Davis said at that is that one of the things I think is highlighted is this right to space and right to air when it comes to work. So I think having an environment where there's ventilation, and now we know we've got these great carbon dioxide monitors. We use a couple of them at the Institute for Work and Health, which just tells you a little bit about how is air circulating through your workplace, knowing that when the environment, when you've got a bit of air circulation, it's probably good. It's not just good for reducing virus transmission, but it's also probably pretty good in terms of just your general health, like feeling like the air you breathe is actually clean. And then, this right to space. So not having to work in cramped conditions, not being right next to each other, to the extent to which people can have a right to space and right to clean air at work, I think is beneficial, not just for infectious disease, but obviously beneficial for worker health and well-being.
Thank you. That's excellent messages. And thank you for a terrific presentation, for all the data. Hope we'll hear more in the future about some of this work and where it's going and how things may be changing. I want to thank everybody who attended the presentation today for attending, and hope that you will join us in February, on February 13th. Dr. Faraz Vahid Shahidi will be addressing the question, is precarious employment an occupational hazard? So do join us again. And thank you so very much, Peter. Hope all of you have a terrific day. Take care.
Thanks, everyone. Bye.